This is Randy Schell, and I'm making a podcast entitled Valvular Heart Disease and Anesthesia. It's part of our University of Kentucky College of Medicine Department of Anesthesiology didactic series. Let's first look at the ABA keywords related to valvular heart disease from the dates shown here, 2005 to 2016. Under aortic stenosis and dysrhythmias. One specific dysrhythmia, atrial fibrillation. If a patient goes into acute onset AFib and they have existing aortic stenosis, you need that atrial kick to fill that stiff, thick left ventricle, and they may need immediate cardioversion if they're hemodynamically unstable. Being able to recognize pressure volume loops in a patient with aortic stenosis, and we'll go over those. Aortic insufficiency. Treatment if they have aortic insufficiency medically, that is afterload reduction, drugs like nitroprusside, increasing contractility, and along with afterload reduction, dobutamine would be an example of that, and not putting in a balloon pump, because a balloon pump inflates during diastole and can worsen the insufficiency, especially in a patient with moderate to severe AI. Mitral valve disease, insufficiency, we can drop the vascular resistance some and decrease the regurgitant volume. Mitral stenosis can raise pulmonary artery pressures, and we will go over both mitral regurgitation and mitral stenosis. IHSS, or idiopathic hypertrophic subaortic stenosis, thickening of the left ventricular septum, resulting in outflow tract obstruction to the LV outflow tract. This is especially important in the perioperative period because any reduction in systemic vascular resistance can worsen that outflow tract obstruction, and we treat it, the hypotension resulting from it, in a patient with IHSS with phenylephrine, with a volume, and even occasionally beta blockers, rather than giving drugs that increase contractility, such as ephedrine or epinephrine. And lastly, there's a couple miscellaneous topics like bacterial endocarditis prophylaxis in patients with valvular heart disease, and some new ways to go about putting valves in patients that don't require sternotomy. Our learning objectives first are to go over some of the pathophysiology of valvular heart disease, to be able to differentiate what happens to the heart in regurgitant, tends to be big dilated hearts, versus stenotic, tends to be a thick heart, i.e. aortic stenosis, thick left ventricle, and to recognize some of the pressure volume curves that are associated with these lesions, and understand a little bit about how to determine whether a valve lesion is severe or not, and to discuss the anesthetic goals for patients who have valvular heart disease who are undergoing non-cardiac surgery. Up at the top right shows a patient with mitral stenosis looking down from the left atrium. Now, management of patients with valvular heart disease depends on the severity of the lesion and whether it's a stenotic or regurgitant lesion. A stenotic lesion, the classic example being aortic stenosis, requires the heart to create an increased pressure inside the left ventricle to get blood out through that reduced orifice, the aortic valve stenosis. A regurgitant lesion example would be aortic insufficiency, where the heart is forced to eject large amounts of volume because during diastole, blood can flow back from the aorta through that insufficient aortic valve and fill the left ventricle, and so it's like blood is going back and forth, and regurgitant lesions often result in very dilated hearts. So stenotic lesions often result in thick left ventricle, AS. Regurgitant lesions, both mitral regurg and aortic regurg, result in dilated hearts. They have to pump a lot of blood and they dilate. Surgical procedure. Well, if a patient's undergoing something that can be done under regional versus major fluid shifts, it will determine what we're going to do with regards to monitoring and anesthetic management. And how well the patient has adapted to their valvular heart disease will determine how we monitor and manage them. For example, do they have good left ventricular function? Do they have pulmonary hypertension? Is their stroke volume maintained, which depends upon preload, afterload, and contractility? What's the natural progression of a patient with valve disease who is left untreated? And this graphic shows survivors percentage on the y-axis, and on the x-axis time since diagnosis. One thing that's interesting to see here is that the lesions aortic insufficiency, mitral insufficiency, and mitral stenosis, the yellow, green, and blues here, have a pretty similar decrement in survivors over time since diagnosis. But aortic stenosis, look at how bad it is. The number of survivors after diagnosis at 10 years is less than 25%. So aortic stenosis is especially bad if left untreated. Let's look at normal left ventricular pressure volume curves so that when we look at abnormal ones, we'll understand them better. Pressure volume curves characteristically show pressure on the y-axis here, and on the x-axis LV volume. And as we go through the steps 1, 2, 3, 4 of what's going on to the heart, let's start at the bottom left where the mitral valve opens and diastolic filling of the left ventricle occurs. That's at 1. Diastolic filling of the left ventricle, blood is flowing from the left atrium into the left ventricle, filling it, and then at end diastole, as the heart starts into systole, it starts to build up pressure inside, the mitral valve closes, and you have isovolumetric contraction at 2, till the pressure builds up and opens the aortic valve, and ejection through the aortic valve occurs at 3, and then the aortic valve closes. As the pressure drops, isovolumetric relaxation is occurring, and we go back through the same cycle again of filling of that left ventricle. So end diastole, bottom right, the difference between end diastole and end systole gives us an idea of stroke volume. So the height of this curve gives us an idea about pressure inside the left ventricle. The width of this curve gives us an idea about the volume in the left ventricle. Looking at it in a little more detail here, again, starting at the bottom left, end systole, the heart has a little residual volume left in it. The mitral valve opens, it fills the ventricle. When the ventricle is full and the heart starts to eject, so this is the end diastole at the bottom right, isovolumetric contraction is occurring. The heart builds up pressure and blood is ejected out through the aortic valve. Then the aortic valve closes again, isovolumetric relaxation. We go through the cycle again, and the width tells us about stroke volume. The bottom right, volume, tells us about end diastolic volume. So if preload goes up, if you dumped in a couple liters of crystalloid or colloid, the preload would go up to this heart and would be shown in the right side as the very first graphic A. In the dotted line represents increased left ventricular volume. Notice that there's a shift in the end diastolic volume to the right. As opposed to increased afterload, which is represented by the middle graphic here, you can see that the heart has to create a higher pressure inside the left ventricle, and so the height of this pressure volume curve is mainly affected. And then increased contractility would be for the same amount of volume in the heart, you generate more pressure inside that heart. So let's look at pathophysiologically some pressure versus volume overload effects on the heart, what it does. Pressure overload first. If there's a pressure overload to the left ventricle like occurs in aortic stenosis, the peak systolic wall tension goes up and the muscle sarcomeres tend to replicate in parallel. And what happens is you get a very thick left ventricle, which then functions to reduce wall tension, but what you see is concentric hypertrophy. So this is the classic patient who has aortic stenosis or long-standing hypertension who gets concentric, thick left ventricle. Now, if you have volume overload on the heart, end diastolic wall tension goes up, the heart is dilated during diastole, lots of volume in it, there's serial replication of sarcomeres end to end, chamber enlargement like LVE, DV dilation, and you get what's called eccentric hypertrophy. AI would be the classic example of eccentric hypertrophy. as opposed to AS, aortic stenosis, as the classic example of concentric hypertrophy. Let's look at now the pathophysiologic pressure volume curves associated with the valvular lesions. Again, on the y-axis you see left ventricular pressure. On the x-axis you see left ventricular volume. Normal is represented by A. B represents mitral stenosis, and you can instantly see that the left ventricular volume is less in this patient. Mitral stenosis, underfilling of the left ventricle. So think of a small left ventricle with mitral stenosis. C represents aortic stenosis. The left ventricle has to generate huge pressures inside to get the blood out through that small orifice, and so the height of this pressure volume curve goes up. So this tall, relatively narrow curve is aortic stenosis. And then if you look at D and E, you see these huge volume hearts where E represents chronic aortic regurgitation, as opposed to D represents chronic mitral regurgitation, both dilated hearts. In the case of D, during systole, you can see this sloping, quite steep sloping back, because blood is being ejected not only to the systemic vasculature, but also back to the mitral regurgitant valve. And you don't have a nice isovolumetric contraction, because as the ventricle starts to contract, blood just leaks right back through that mitral valve. So you can kind of recognize some of these patterns of stenotic versus regurgitant lesions. If we look at a visual picture of what aortic stenosis looks like depending upon the cause, at the far left is calcific aortic stenosis. This would be the classic 80-year-old with aortic stenosis who you pick up a systolic murmur. And you can see during systole and diastole here, the aortic valve doesn't open very far. It's got heavy calcification. As opposed to a patient with a bicuspid pathophysiology of aortic stenosis, they often present earlier, 40, 50, maybe 60, but definitely earlier than calcific aortic stenosis. And in this case, they're born with a bicuspid valve, and you can see that over time that fish mouth-like aortic valve becomes calcified and thickened and doesn't open as well, and aortic stenosis pathophysiology occurs secondary to congenital bicuspid aortic valve. Rheumatic disease is associated with inflammation, and both the mitral and aortic valve are often involved, in this case showing a picture of the aortic valve with commissural fusion from the inflammation. The valve becomes very inflamed, it scars down, and only the little central part opens. Commissural fusion, a characteristic of rheumatic aortic stenosis. Aortic stenosis, as you know, is a systolic murmur, and this is showing it here in the yellow triangle. A crescendo, decrescendo, systolic murmur. And if we look at the natural history of these lesions, aortic stenosis, from the time of onset of symptoms, shown up at the top right, you can see that there are three major symptoms that we talk about: heart failure and syncope and angina. And from the time of onset of symptoms like heart failure, syncope, or angina, if you don't have aortic valve replacement, you're not going to live very long. A little bit longer after heart failure symptoms than syncope and angina maybe, but all three of them are associated with, from the onset of those symptoms to death without valve replacement, not very long period of time. Well, why do they get heart failure? Well, because they're pumping against a resistance. Why do they get syncope? Well, let's say you exercise and vasodilate distal to that aortic valve. Your heart can't get enough blood out there to fill that dilated vasculature. Your blood pressure drops significantly and you faint. Angina, because you have a big, thick left ventricle that's trying to get blood from the epicardium into the endocardium. The endocardium is at risk, and even without flow-limiting coronary artery disease, i.e. lesions in the coronary artery, you can still get angina in patients that have aortic stenosis. So let's look kind of in a algorithm-based format the pathophysiology of aortic stenosis. We'll start at the top. Aortic stenosis is present, obstruction to outflow through the aortic valve. The left ventricle has to pump against that. It starts to grow and thicken. Left ventricular mass goes up. And early on, the heart's not very compliant because it's like thicker muscle and you have some form of diastolic dysfunction. But contractility is maintained. Ejection fraction is maintained. End diastolic pressure goes up inside the heart, and you're much more dependent upon the atrial contraction, which maybe in a healthy state contributes 20-25% or so to the filling of the left ventricle, and in the case of aortic stenosis, this may far exceed 50%, such that if a patient loses their atrial contraction who has aortic stenosis, they may become very hemodynamically unstable. They need that atrial contraction to fill that stiff, high-pressured left ventricle. And onset of AFib may require immediate cardioversion in these patients. Now, late, the left ventricular mass itself, the muscle can fibrose, the contractility can start to decrease, ejection fraction goes from normal, now less than 60% to 50 to 40%, and if nothing is done, this patient's going to die in a short period of time. So valve replacement, we hope, is done before you start seeing these decrements in LV function. Eventually, the left ventricle dilates, the mitral valve apparatus can be pulled apart and get mitral regurgitation, stroke volume goes down, and terminal events occur. Aortic stenosis creates, again, an outflow tract obstruction, or an LV outflow obstruction, that is, and the systolic pressure inside the left ventricle goes up. That's the reason for the increased LV mass. It uses more oxygen because it has more muscle. The time in ejection, the left ventricular ejection time, goes up. It's ejecting for a longer period of time, needs more oxygen to perform that muscular ejection. There's an increase in left ventricular end diastolic pressure, so the pressure inside the heart at end diastole is actually higher. Instead of being 10 or 12, it might be 18 or 20. And the combination of less diastolic time and higher diastolic pressure is a bad thing, because diastolic time is when coronary blood flow to the left ventricle occurs, and that's when the myocardium is getting its oxygen. So it's using more oxygen, getting less oxygen, and can have myocardial ischemia even without flow-limiting coronary artery lesions. Now, if we look at valve areas of the aortic valve versus flow being on the y-axis in this graphic on the left, aortic valve pressure on the bottom on the x-axis. This is showing a normal valve area up at the top, and then as it decreases the valve area all the way down to this magical 0.8 to 1 range, which most books will tell you is the critical severe aortic stenosis. By definition, usually most use 1 centimeter squared valve area as severe aortic stenosis. Some books will tell you 0.8, and critical means that no matter what pressure you generate in the left ventricle, you can't get any more flow across that aortic valve. It's flow limited, and so at that point, if systemic vascular resistance drops, there's nothing that patient can do. They cannot generate more pressure in the left ventricle to get more blood to go through it. And again, up at the top right, you can see the pressure volume curve, the characteristic one of aortic stenosis that shows very high pressures inside the left ventricle. And initially, as long as it's not a failing dilated heart, it is not a big heart. So high pressures is the characteristic finding inside that heart with aortic stenosis. Aortic stenosis creates turbulent flow through the little orifice. And that's one of the things we look for on echo, the presence of turbulent flow. And there's several views, and we'll just touch on some of these views as we go through to introduce them to you if you haven't been before. But the first one is the mid-esophageal long axis view, meaning that the probe of the TEE machine is sitting in the mid-esophagus, and long axis being through the aortic valve and long axis, as opposed to the mid-esophageal aortic valve short axis, which is 90 degrees from the long axis. you can see the 3 leaflets, assuming it's a tri-leaflet aortic valve, with the non-coronary cusp sitting next to the atrial septum, the left coronary cusp, which the left main comes off of, and the right coronary cusp, the most anterior. So aortic valve in cross-section, aortic valve in long section, or long axis. We do some measurements. We can measure the annulus, we can measure the aorta. Aorta can often dilate, post-stenotic dilation after long-standing aortic stenosis. If you stop the picture and trace out around the opening, which isn't a very accurate way of doing it, but can be done, this is called planimetry, and we can get the opening size of the aortic valve. In this case, you can see it as 0.9 centimeters squared, which is severe aortic stenosis. Another view that we use is what's called the deep transgastric long axis view, where the probe of the TEE is sitting in the stomach and shooting up through the apex towards the aortic valve. And in this case, LA stands for left atrium, LV stands for left ventricle, and AV stands for aortic valve. Aortic root is the part from the aortic annulus up to the sinotubular junction right here. So when you hear about a root replacement, this is what they're replacing. But why do we get this view? We get this view because we can line up a continuous wave Doppler here through the aortic valve and get a trace that looks like this, and put a little cursor on it and find out the peak gradients. And if we trace over this, we can actually get mean gradients also. So continuous wave Doppler is used to measure the severity of aortic stenosis. And if we look at the mean gradient and the valve area, when you get over about a 40 millimeter mercury mean gradient, that correlates in many patients with a valve area of about a centimeter squared. So if the gradient's high, the valve area calculated is less than centimeter squared, the jet velocity is very high, we start thinking this is bad aortic stenosis. In the cath lab, they'll occasionally measure the gradient, and there's a difference between the gradient that's measured in the cath lab versus measured on echo. And let me just touch on this very briefly. On the top left shows what it would look like in the cath lab if you had a catheter inside the left ventricle, which would be the LV trace here, the highest one, and one out in the aorta. So you're measuring pressures across the aortic valve, both before it and after it. And the maximal pressure gradient is shown here, as well as what's called the peak-to-peak gradient, which you can see is not occurring at the same time. The left ventricle creates a high pressure, and there's some time after that the highest pressure is created in the aorta, because obviously the aortic valve has to open and blood has to eject. So that's called peak-to-peak gradient. They're not at the same time. As opposed to using continuous wave Doppler to look at the maximal velocity of the jet going across, this is called Vmax, and that's the maximal gradient by echo, which tends to exceed the peak gradient in the cath lab. And there's some big equations that can be used to estimate the aortic valve area in the cath lab, and there's something called the continuity equation, which can be used to better quantify the aortic valve area, but we will not go into that detail in this podcast. Treatment of aortic stenosis: if you have severe aortic stenosis, the classic area being less than 1 centimeter squared, as we mentioned, with the mean gradient greater than 40 millimeters of mercury. If they're already undergoing coronary artery bypass graft surgery, that's a class 1 indication. You better just replace the aortic valve at the same time. If the patient has symptoms, you're going to go right to aortic valve replacement with those measurements of 1 centimeter squared or less, a mean gradient 40 or more. If they're symptomatic, maybe not, you're not sure, you can do an exercise test. Blood pressure goes down, you're going to take them to aortic valve replacement probably. And if these things are equivocal and their ventricle is good, and you may wait for some time before you take them to valve replacement. But the presence of heart failure or angina or syncope symptoms, these patients need aortic valve replacement, because we showed you before what happens if you don't do anything to the valve over time. Now, valve replacement can be done with bioprosthetic valves, which are shown in the bottom right here, an example, and prosthetic valves made out of materials such as shown here, carbon materials, metallic materials. And so these artificial heart valves, two major types. Up at the top right with the little star is like a tilting disc, bileafleted tilting disc. And at the bottom right is the strutted, notice the struts here, bioprosthetic valve. Now, aortic valve replacement also can be done percutaneously. In patients that are extremely high risk, is what we used to do in the past, older patients, decreased ejection fraction, percutaneous aortic valve replacement has been done. These indications are becoming wider now for replacing valves, not through a sternotomy, but through other approaches, such as transfemoral, transaxillary, transapical. Up at the top left, A through D is showing a balloon going in across the aortic valve. The catheter is present across the aortic valve with the artificial valve, which as the balloon goes up and spreads that artificial valve and its little struts open in the position of the aortic valve, you now have aortic valve that's open with a strutted or with a supporting wire mesh apparatus that's holding that aortic valve open with a aortic valve in the middle of it, and just the simple deployment of this puts an aortic valve in place without having to open the sternum, open the chest, etc. In some cases, not opening the chest. Now, one of the questions, key words that the ABA asked in the last couple of years was, what are some of the complications of this form of aortic valve replacement? Well, one is if you're going through major vessels like the femoral vessel, you can get vascular dissection, perforation of vessels, retroperitoneal bleeding, aneurysm formation, gut ischemia, and there's multiple ways that you can put catheters in through the femoral vessels, through the transaxillary, through the apex of the heart, through the ascending aorta itself, and each of them are associated with some complications more than others. But stroke, myocardial ischemia, rupture, dissection, etc. are some of the complications of aortic valve replacement done in this method. So some treatment goals for patient with aortic stenosis, big red arrows pointing to the aortic stenosis. The two major points are: one, afterload. You do not want afterload to go down. The heart cannot get blood through that small little orifice to fill the dilated vasculature. So turning up your inhaled agent, high concentrations, turning on nitroprusside, those would be very bad things to do. Phenylephrine treatment of hypotension would be a good thing. Rhythm, we really want that patient in sinus because we remember pointing out the importance of the atrial kick to filling of that thick, non-compliant left ventricle. So keeping the afterload up, keeping the rhythm sinus, and preload maintained and contractility maintained, that's the best things that you can do in a patient with aortic stenosis. A couple clinical pearls here. One, spinal anesthesia and epidural. If you put in a spinal anesthetic and have a rapid onset of sympathectomy, T1 through L2, your sympathetic nervous system, and you decrease the preload and you decrease the afterload, this is not going to be good for that thick, non-compliant left ventricle that needs to be filled and needs afterload up, and patients can become severely hypotensive. So putting in a spinal anesthetic in a patient with aortic stenosis that's severe, probably not a wise thing to do. Goals for general anesthesia: keep their SVR up. Sometimes phenylephrine infusions are used during induction to keep that SVR maintained, keeping preload up because that thick, non-compliant left ventricle needs to be filled. And if they went into a rhythm outside of sinus, trying to get them out of that and back into the atrial kick sinus rhythm that they need. Etomidate and opioids are especially useful in these patients. Remifentanil, etomidate, for example. Patients who have AS can have angina even without flow-limiting lesions, as mentioned earlier, and that's mainly because they have this big, thick left ventricle, and the epicardial coronary arteries are trying to go all the way from the outside of the heart to the inside of the heart. That endocardium is especially at risk for ischemia, because not only is it a long distance through a thick left ventricular muscle, but also the pressure inside the heart, left ventricular and diastolic pressure, is high. And remember that coronary perfusion pressure is diastolic blood pressure minus LVEDP. If LVEDP is high, that can negatively impact coronary perfusion pressure. And we don't want the patient to get tachycardic because that will increase oxygen demands of the heart also. Another pearl is this atrial fibrillation concept of needing the atrial kick. If a patient with aortic stenosis loses their atrial kick and becomes hypotensive, remember, cardiovert early rather than waiting. CPR, if needed in a patient with aortic stenosis, chest compressions are not going to be very effective in generating adequate pressures across that aortic valve. So early instigation of therapy before they get to this needing CPR. Aortic insufficiency, let's move on from AS. Up at the top right shows a picture of blood leaking back through an aortic valve during diastole. And on echo, you can see the picture at the top right, that blue jet from the aorta through the aortic valve into the LV tract into the left ventricle. The etiology of aortic insufficiency could be rheumatic fever, could be destruction of the valve from bacterial endocarditis, trauma like chest trauma after a motor vehicle accident, dissection of the aorta, dissects down and interrupts the competency of that aortic valve. When you have aortic insufficiency, there's volume that's overloading the left ventricle. During diastole, that blood is leaking back in the left ventricle, filling it up, and it dilates over time. You get a massively big, dilated heart, eccentric hypertrophy, remember. Compensation is large stroke volume. You fill that heart with a lot of blood, it's got to get rid of it, so it's got a huge stroke volume. The peripheral vasodilation will help reduce aortic insufficiency, and the heart rate goes up because the more time you spend in diastole, the more time there is for blood to leak back into the left ventricle and fill it. So we want the heart rate a little fast, vasodilated, and we'll talk about some of that in the clinical pearls discussion in just a couple slides. Let's go over the pathophysiology of AI now. If it's a volume overload of the left ventricle, the fiber length goes up, there's dilation. If the heart dilates a lot, it can pull apart the mitral apparatus and pull apart the mitral valve annulus, and you can get mitral regurgitation, blood leaking back into the atria and into the pulmonary system and causing pulmonary hypertension and eventually right heart failure. The heart dilates over time, and that reduces the oxygen cost. But a heart over time can get huge. The pressure inside not only the left ventricle but the left atrium can get high, also contributing to the pulmonary hypertension that may be seen in long-standing aortic insufficiency. And eventually you get a failure of the heart with reduced stroke volume. It just can't keep that up over time. This pressure volume curve is attempting to show the difference between acute AI versus chronic AI. First thing you can see is chronic AI has a huge heart. Look at end diastole over here, 300, 350, 400 cc's of blood in this heart. As opposed to acute AR, it's not as big of a heart, it hasn't had time to dilate, but look at end diastole, the pressure. Because the heart hasn't had a chance to dilate and take up the pressure from all this blood coming back, if acute AI occurs, such as a healthy patient, motor vehicle accident, chest crunch, aortic valve becomes incompetent, all that blood backs up and the LVEDP goes up very high and the patient can go into pulmonary edema quickly. As opposed to the patient with chronic AI, over time the left ventricle dilates. So much bigger heart if the heart has had time to dilate. How do we quantify AI? Well, it's a little bit more difficult, some aspects, than AS, but one of the things that is looked at is the width of what's called the vena contracta. If you look at the place where blood's coming through the aortic valve, right almost at the annulus, that little width of that jet as opposed to the width of the LV tract gives us an idea how severe the AI is. For example, if the width of this jet fills the whole LV tract, that's pretty bad. If it's just a teeny little narrow jet, suggests that it's not as bad. So the width of the jet is called the vena contracta, and it's one of the things that's used to estimate aortic insufficiency. Other things like regurgitant fraction, regurgitant volume, effective regurgitant orifice area are complicated in quantitative ways that echo is used to assess AI. So what do we want to do in patients with AI clinically? Well, if the afterload is decreased, there'll be less AI. The pressure in the aorta will be less, and the blood will not go back as much through that aortic valve. So turning on nitroprusside, turning on inhaled agent, which would vasodilate the patient, promotes forward flow. So keep the afterload down. You can't put a balloon pump in these patients, remember, because in moderate to severe AI, that aortic balloon pump will inflate during diastole, create higher pressures during diastole, and force blood back into the left ventricle. So you need a competent aortic valve, or at least only mild AI, if you needed to put a balloon pump in to support the left ventricle. The rate, it'd be nice if it's a little bit faster in AI. Why? Because less time in diastole, less time for it to fill during that diastolic phase where insufficiency is occurring. Some clinical pearls related to AI. Again, the graphic on the top right is showing pressure volume, and you remember that AI is a regurgitant lesion and therefore has a big dilated heart, and chronically would be E in this picture at the top right. Now, if someone has AI and you want to put a spinal or an epidural, it's not contraindicated as long as you keep the preload maintained. Dropping the afterload actually can be good and reduce the regurgitant amount through the aortic valve. For general anesthesia, you really don't want their afterload to go up. So intubating someone lightly, for example, and their pressure jumps from 120 up to 200 and they get tachycardic, that sudden increase in afterload can raise aortic pressure and make more blood go back through that aortic valve. So we want to decrease afterload, and our inhaled agents, Sevo, Des, and ISO, do that. And we want to avoid bradycardia because with bradycardia, there's more diastolic time, and it's during diastole that blood is leaking back into the left ventricle. Medical management of acute AI was multiple keywords between the years 2005 and 2016 from the American Board of Anesthesia. So let's touch on that here. A patient has a disrupted aortic valve for whatever reason, and it's acutely leaking. They don't have time to dilate, and therefore there's very high left ventricular and diastolic pressures, and it backs up into the lung, and they often have pulmonary edema, require intubation, mechanical ventilatory support, but then we want to reduce the amount of blood that goes through that incompetent aortic valve, so turning on a vasodilator to decrease systemic vascular resistance, nitroprusside would be an example, turning on an inodilator like dobutamine, which via its beta-1 effect increases contractility, via its beta-2 effect results in dilation, therefore the inodilation. And also remember that intra-aortic balloon pump is contraindicated because of the fact that it raises diastolic blood pressure and will increase flow into the left ventricle. Let's look at the mitral valve now. Since we've touched on aortic stenosis and aortic insufficiency, we'll now look at mitral stenosis and mitral insufficiency. The valve at the top left is a mitral valve taken from a heart, removed, and the chordee cut, and you can see the anterior leaflet at the top, the posterior leaflet at the bottom. At the top right is a four-chamber view of the mitral valve, and in that case is a mitral stenotic valve. Notice the big left atrium, the mitral valve that isn't opening very much and has a small orifice. At the bottom left graphic is showing the anterior leaflet and the posterior leaflet, and there are designations to portions of these leaflets called anterior 1, anterior 2, anterior 3, and P1, P2, and P3. On an echo, that can be used to determine exactly where the leaflet pathology is. So if someone said they had a P2 flail, that would mean that the flail of the leaflet was in the P2 segment. Again, that's beyond the discussion at this point, but just to introduce you to some of the concepts of echo used to help diagnose the location as well as the severity of valve disease. And if you look at the mitral valve, it involves not just the leaflet, but the valve apparatus, being the chordae tendineae, the papillary muscles attached to the left ventricle, any part of these that become disrupted or damaged, i.e. papillary muscle disruption from ischemia, a flail leaflet from a chordae rupture, a endocarditic leaflet that has holes in it and is destroyed, or the wall of the left ventricle that becomes ischemic or infarcted. All of those can disrupt mitral valve function and cause problems. Let's look at mitral stenosis first. Rheumatic fever, severe calcification, myxomatous lesions in the left atrium, not real common, but can also cause mitral stenosis, and endocarditis can cause regurgitation and stenosis. So at the top right shows a graphic of what aortic stenosis would look like. The stenotic, that is mitral stenosis, would look like. The stenotic mitral valve is here. The left atrium is big. There's a hockey stick-like appearance of that mitral valve and restricted opening of it such that there's a very small orifice. And if we looked at that in long axis, the graphic at the bottom shows that left atrial enlargement in those very poor opening of the tips of the mitral valve leaflet, commissural fusion, and if you looked at it in short axis, you could see that teeny little opening. So mitral stenosis, reduced mitral valve opening. And mitral stenosis causes a diastolic murmur as blood is flowing from the left atrium through a stenosed mitral valve into the left ventricle during diastole. You hear that diastolic murmur. And it also often is a decrescendo and then pre-systolic accentuation, crescendo murmur during diastole. But the main point is it is a diastolic murmur. Again, remember, aortic stenosis is a systolic murmur. Aortic insufficiency is a diastolic murmur. And now we have mitral stenosis, which is a diastolic murmur. Let's look at an algorithm for mitral valve disease pathophysiology. At the top, you can see stenosis or regurgitation can back up pressures into the pulmonary artery system. And if the pulmonary artery pressures go up, you can get right ventricular hypertrophy and right ventricular failure. You can get dilation of the annulus in the right side of the heart. Tricuspid valve can become regurgitant, and it can back up such that the liver becomes huge. And eventually, right heart failure can occur along with left heart failure. Mitral stenosis causes an increased gradient across the mitral valve such that the left atrial pressure goes up. As the left atrial pressure goes up, the left atrium tends to enlarge over time, going from the normal 4 centimeters or so, and many times you can see 6 and 7 and 8 centimeter left atria that are in atrial fibrillation commonly because of their dilation. And when they're huge and atrially fibrillating, little clots can form, especially in the appendage, such that thromboemboli can occur, and these patients are anticoagulated. And if you're going to cardiovert them, you need to make sure that there's not a clot stuck in the atrial appendage. Now, as left atrial pressure goes up, pulmonary venous pressure goes up, and pulmonary hypertension, and again, right-sided failure, right-sided dilation, tricuspid annular dilation, and tricuspid regurgitation can occur. So left-sided mitral stenosis can cause right-sided failure and pulmonary hypertension. Now that mitral valve, when it gets really small, in fact when it gets down to about 1 centimeter squared, that's critical mitral stenosis. Critical in the fact that no matter what pressure you generate across that mitral valve, and that's on the x-axis, mitral valve pressure gradient, no matter what that gradient is, you can crank it all the way up to 50 here, and no more flow goes across the mitral valve. So it's critical at 1 centimeter squared approximately. And the flow characteristics and oncotic characteristics and hydrostatic characteristics of blood vessels in the pulmonary system are such that if the pressure gets too high, it's going to exceed oncotic pressure, and you're going to force fluid through the alveolar capillaries right into the alveolus itself, and you're going to get pulmonary edema. So pulmonary edema can occur with mitral stenosis. And up at the top right is showing a mitral stenosis pressure volume curve, pressure on the y-axis, volume on the x-axis, and you have an underloaded left ventricle is the classic appearance of such. On TEE, there's several views that we look at. One is a short axis view of the mitral valve, which shows the fish mouth appearance. And the other one that we classically look at is the mid-esophageal forechamber, where you see the left atrium and left ventricle and the mitral valve here. And there are some other ones like the commissural view we can look at to see whether those commissures are fused or not, and the mid-esophageal two chamber, which is really good for looking at the left atrial appendage to see if clots are present there. And when we look at it, the mitral valve under echo, TE at the bottom left is a great way to look at the left atrium, left atrial appendage, size of left atrium, and the mitral valve, because it's right near the probe, which sits just behind the left atrium and the esophagus. And here's that hockey stick appearance of a mitral stenotic valve, reduced opening, and oftentimes these leaflets are restricted in mobility and calcified, very white, for example. Here's a transthoracic echo picture on the top showing again dilated left atrium, hockey stick appearance of the leaflets of the mitral valve, and reduced orifice opening. And if you looked at it in short axis, you can see that the little fish mouth is small, indicating that the orifice size is small. One of the things that we can do to quantify a mitral stenosis is to put a pulse wave Doppler right at the annulus or at the tips of the mitral valve, and here it is during diastole. Blood is flowing through a normal mitral valve in this case, the blue flow away from the probe across the mitral valve. And if the sample volume was right at the mitral valve leaflet tips or so, what you see is during diastole, notice on the EKG, diastole being from the T wave all the way to the QRS complex. So this is diastole. You get an E and an A wave. An E wave refers to the passive filling that occurs when the atrium starts to empty. When the mitral valve opens, blood flows across, and then diastasis, when the pressure is equalized between the left atrium and left ventricle, and then the atrial kick, assuming that they are in a sinus rhythm. And so if there's a P wave down below, you'd see that atrial kick. Now, when we look at mitral stenosis patient with echo and put that little Doppler signal between the atrium and the ventricle at the tips of the mitral valve leaflet, we can look at the peak gradient. The higher the velocity across that little orifice, the worse the mitral stenosis. So the peak and mean gradient can be based on the velocity of blood flow across this mitral valve. And another thing that we look at is how long does it take for a decrease in velocity across the mitral valve? And that's called the pressure half time. And basically, to make a long story short, if you have a wide open mitral valve, this velocity falls off very quickly, as opposed to a small little orifice. It falls off over longer periods of time, and we say there's a long pressure half time, and we can use that to estimate the mitral valve area. So the pressure gradient across it and the pressure half time across it are used to quantify mitral stenosis. And if we have an area less than 1 centimeter squared, remember the aortic valve area less than somewhere around 1 centimeter squared also is considered quite severe. The mean gradient for aortic valve was 40. In this case, a mean gradient from left atrium to left ventricle of greater than 12 is considered severe. And if you have concomitant pulmonary artery mean pressures greater than 50 associated with it, that's also severe. Well, what do we do with a patient with mitral stenosis clinically? Well, we need to keep the preload maintained, because that left atrium has to be filled to try to get blood squeezed across that small mitral orifice. But if you give a whole bunch of fluid or put a person in head down position who has mitral stenosis, you can actually put them in acute pulmonary edema. Now you think, well, why don't I just decrease the afterload a little bit? And that's a bad thing, to try to decrease left-sided afterload. Why? Because blood is trying to get through that orifice of the mitral valve, and if you dilate the left side, it can't get enough blood through that orifice to fill your body, and your blood pressure tends to drop. So turning on a drug like nitroprusside would be a really bad idea. But remember, blood is backing up from that stenotic mitral valve into the atrium, into the pulmonary system, so they often have pulmonary hypertension. And so reducing right-sided afterload is something we should do. So don't let them get hypercarbic or hypoxic or acidotic, things that constrict the pulmonary vasculature. The right ventricle may not be working too well because the pressures have gone back through the pulmonary system, and pulmonary hypertension and right heart failure can be occurring. And we really, really want the atria to be contracting on its own. That would be nice to push blood across that stenotic mitral valve, but often they're in atrial fibrillation. We often just have to control their ventricular response with drugs that slow AV conduction. So some clinical pearls for mitral stenosis. What about the pregnant patient with mitral stenosis? Remember, during pregnancy, your intravascular volume goes up. And as your intravascular volume goes up, left atrial pressures can go up, and symptoms, pulmonary edema, can get worse, especially immediately after delivery, where you get all that increased volume from the uterus contracting down, and the blood volume goes up, and cardiac output goes up shortly after delivery. That is the time where they can go into failure. Spinal anesthesia is not a great idea. Why? Because you will drop afterload, and you can't get enough blood across that stenotic mitral valve to fill the dilated vasculature. If a patient will happen to be in sinus rhythm and then went into new onset atrial fibrillation and lost their atrial kick, which was so good for squeezing blood across that stenotic valve, that's the patient who often is severely hypotensive, and cardioversion could be indicated. Remembering again that cardioversion, for someone who's in chronic AFib, you really need to make sure that there's not a clot sitting in the atrial appendage. Some pre-medication issues with severe MS. If you have a patient with mitral stenosis and you give them, let's say, fentanyl or midazolam, and they hypoventilate, and their CO2 goes from normal of 40 up to 50, PCO2 of 50, hypercarbia is going to cause an increase in pulmonary vascular resistance. And if they already have pulmonary hypertension and right heart issues, you're going to make those worse. So be very careful about pre-medicating a patient with mitral stenosis, and in most cases we avoid pre-medication. So some factors that might worsen pulmonary hypertension in a patient who has severe MS and blood backing up already and pressures backing up into the pulmonary system, it's all the bad things. Hypoxia, hypercarbia, acidosis, light anesthesia where norepinephrine levels go up and cause vasoconstriction through alpha-1 mechanisms. And exogenous alpha agonists like norepinephrine and phenylephrine can raise pulmonary vascular resistance. Vasopressin may not have quite so much effect on the pulmonary vasculature as does norepinephrine and phenylephrine. And then if you let a patient get cold, they often will get vasoconstricted in the pulmonary vasculature. So if you already have pulmonary hypertension, don't let them get hypoxic, let their CO2 go up, let them get acidotic. If their catecholamines rise because you stimulate them, i.e. laryngoscopy in a light anesthetic state, pulmonary vascular resistance can go up dramatically, and then don't let them get cold. Let's finish up with mitral regurgitation and IHSS, and then some miscellaneous topics. But mitral regurgitation, how can it occur? Well, mitral valve prolapse could be one where the leaflets just billow into the left atrium. They could have disruption of the chordal apparatus that holds that mitral valve in place, like the papillary muscle or the chordae tendineae, from ischemia, or just old patients sometimes can have degeneration of the chordae and just rupture. And LV dilation, if a patient has failing left ventricle that's dilating, it can pull the annulus apart and cause a central, often jet going back into the left atrium during systole. And endocarditis can eat away at that leaflet and cause mitral regurgitation. Now, mitral regurgitation pressure volume curve is shown at the left here, and you can see that it is a systolic murmur. So during left ventricular systole, blood's going back through the mitral valve, and that's when you hear the murmur. Acute versus chronic is shown here. Big left ventricle during regurgitation lesions like AI and MR. And so you can recognize it by, on the x-axis, the large volume 1, and then during isovolumetric contraction, where the volume should stay the same, go straight up and down, blood is going back into the right atrium, and left ventricular volume is getting smaller, when during isovolumetric contraction it should stay the same until the aortic valve opens. And that's because it's leaking back through the mitral valve. The pathophysiology is discussed here, whether it's acute or chronic. And let's do acute first. You have a sudden disruption of a papillary muscle or a chordae tendineae. Forward stroke volume goes down, backward stroke volume goes up, so they're going to be hypotensive, and their body responds with high sympathetic tone. The LVEDV is going to go up, end diastolic volume, end diastolic pressure goes up, blood is backing up into the pulmonary system, hydrostatic pulmonary edema can occur, pulmonary hypertension, and right heart failure. So this is the patient who has, for example, a papillary muscle disruption from coronary artery disease, myocardial infarction. A patient with chronic MR has time to dilate their left atrium, and oftentimes it will go from that 4 up to 5 and 6 and 7 and 8 centimeters, huge left atrium that is more compliant, can accept that blood over time, and preserve the low pulmonary venous pressures. Now it's dilating to compensate for the mitral regurgitation and try to keep those PA pressures down. As opposed to, on the top picture here, you can see that acute mitral regurg, the LV doesn't have time to dilate, and the LA pressures are high. The LA pressures are normalized as they dilate in the chronic state. How do we check the severity of mitral regurgitation? One is the size of that big jet going back into the left atrium. The size of the left atrium itself, the bigger it is over time, probably the worse the jet. The leaflet pathology, is it a flail flipping up leaflet into the left atrium with each systolic contraction? And one of the things that we look at is, does the blood go all the way back and go into the pulmonary vein, such that during systole, the contraction of the ventricle and blood going back through the mitral valve goes all the way up into the pulmonary vein and causes what we call systolic reversal of flow in the pulmonary vein. And if they do have that, that's considered severe mitral regurgitation. So this is just showing a brief example of the area that the jet fills. The bigger the area it fills, the worse it tends to be. And then if it goes all the way back and reverses flow in the pulmonary vein, and in this case, if you see a QRS, that obviously is systole, and blood should be going from the pulmonary vein into the left atrium during both systole and diastole, but in this case, systole it reversed, diastole it's still going forward, and then atrial reversal as the atria contracts. So this waveform is below the line when it really should be above the line. Blood should be going through the pulmonary vein into the left atrium rather than the left atrium into the pulmonary vein during systole. That's called systolic reversal of pulmonary venous flow. Indicator of severe MR. So mitral valve replacement or repair, if it's a intact mitral valve with, let's say, a chordal rupture but not heavily calcified or thickened, you might repair it. Or in some cases put a ring and do another form of repair. But this is just showing an example of a replacement with a St. Jude valve or an annular ring as part of a repair. The annular ring is shown here extending around the posterior towards the anterior, often open in the anterior part here in this case, and that helps keep the annular size intact and the mitral valve leaflets pulled together. And in the bottom is a St. Jude valve, a tilting disc, bileafleted tilting disc valve put in the mitral position for a replacement. If you have someone with severe MR, moderate to severe MR, for non-cardiac surgery, what are some of our goals? Well, one, if we can keep their afterload down, more will go forward and less backwards. So vasodilation is good in the case of mitral regurgitation. The rate, be nice to a little bit faster rate to improve the cardiac output. And it's not so critical that they maintain their atrial kick, but they're often those patients, if they've been in chronic regurgitation, have dilated the left atrium and may be in atrial fibrillation. So one of the big things you can do is reduce afterload. And in this case, if you needed to support the left ventricle, an intra-aortic balloon pump could be placed, because if the aortic valve is intact, it will increase diastolic blood pressure and flow through the coronary arteries and reduce afterload, systolic blood pressure, and maintain more forward flow and decrease MR. So a balloon pump is not contraindicated in mitral regurgitation. So some clinical pearls. One, putting in a spinal epidural, not a big deal usually. Decrease in afterload may actually improve the MR, reduce it. In our general anesthesia goals, we want the afterload to go down, and our volatile anesthetics do that. They're vasodilators. And we want to avoid anything that increases pulmonary vascular resistance. If blood is already going backwards into the pulmonary system with high pressures, we don't want to raise the pulmonary pressures higher with hypoxia, hypercarbia, hypothermia, light anesthetic state, vasoconstrictors, etc. And keep the heart rate relatively fast. One of the important points about echo and ejection fraction in mitral regurg is that when someone has an ejection fraction reported, let's say of 60%, but has severe MR, you say, hey, that's a good ejection fraction, 60%, normal, right? Well, they're ejecting some forward and some backward, and so that ventricle has a little bit easier job in some ways, because it's not having to make all the blood go forward. If you suddenly put in a competent mitral valve and make that ventricle pump everything forward, suddenly that LV dysfunction that's present, but you couldn't see it, may become evident, and their ejection fraction instead of 60% now looks like more like 20%. And it may uncover a baseline poorly functioning left ventricle and require inotropic support. Some pearls continued. If you have acute MR, such as a ruptured chordae, patients in the ED with myocardial infarction and a ruptured chordae, large amount of blood is going back into the left atrium, they haven't had time to dilate, their pulmonary artery pressures go up dramatically. What you can do is drop their SVR, vascular resistance, with a drug like nitroprusside, make more go forward than backwards. You can put in a balloon pump, and you can add inotropes to support them until you can get them to the operating room. So that's called medical management of acute mitral regurgitation. Don't forget bacterial endocarditis prophylaxis in patients with valvular heart disease. We'll touch on that at the very end about making sure that we give antibiotics to these patients. Tricuspid regurgitation. About 80+% of us have some amount of TR, and so if you do a echo on most patients, there's a little bit of tricuspid regurgitation. And the classic view from transesophageal echo is the mid-esophageal four-chamber view, which you see the left atrium, the left ventricle, right atrium, right ventricle, the tricuspid valve, and the mitral valve. So we're focusing on the right side, the tricuspid valve, and we said that most people have a little bit of TR. One of the most common causes of tricuspid regurgitation is left heart failure, where blood backs up and causes right heart failure, and the right heart dilates and pulls apart the tricuspid annulus, and you get TR. Another cause is the valve being eaten away by bacteria in patients that use drugs, IV drug use and right-sided valve lesions. Another view for TE and tricuspid valve, other than the four-chamber, which we showed you before, is this what's called mid-esophageal RV inflow-outflow, right atrium, right ventricle, tricuspid and valve in between. A good view to line up a Doppler across it. Now, why would I want to line a Doppler across it to look at the tricuspid valve regurgitation velocity? This is a somewhat complicated idea. but I'm going to try to make it as simple as possible. When you are looking preoperatively, for example, at a patient who's had a transthoracic echo, and somewhere on the report the cardiologist says the estimated RV systolic pressure is 28 or whatever they say, you go, where did they get that? How do they know what the RV systolic pressure is? How do they know what the PA systolic pressure is? Because those are usually equal if the pulmonary valve is not abnormal. So they're giving you an estimate of the pulmonary artery systolic pressure non-invasively. And the way they do that is they line up a Doppler across this tricuspid regurgitant jet, and this jet will have a higher velocity if the pressure on the right side, right ventricle, is much, much, much higher than the right atrial side. And the greater the differential in pressure between the right ventricle and the right atrium, the greater will be that velocity of jet during systole. And there's an equation that can be simplified down to the one that's in red at the top, that the RV systolic pressure equals 4 times the velocity squared of the tricuspid regurgitant jet plus the central venous pressure. So I gave you an example at the bottom here where a continuous wave Doppler was placed across a tricuspid regurgitant jet. We get a trace like this. The velocity in this case is about 3 centimeters per second, or 3 meters per second, that is. And so we can put that into the equation, and if it was 3, it would be 4 times 3 squared, or 4 times 9 would be 36, plus you add the CVP to it. And if it was 4, in the example below, the jet velocity 4 meters per second, which is very high velocity, you'd say 4 times 4 squared, or 4 times 16, is 64, and let's say the CVP was estimated at 10, the cardiologist would say that's a 74 estimated millimeters of mercury RV systolic pressure, or PA systolic pressure. That's pretty high. And so this is how the cardiologist gets RV systolic pressure from the TR jet on your preoperative echo. 4 times the velocity squared plus CVP. So in tricuspid regurgitation, really what you want to do is you want to maintain RV function and decrease the pulmonary vascular resistance so that more blood goes forward. Now, how do you decrease pulmonary vascular resistance? Oxygen. Don't let the CO2 go up. Don't let them get cold. Don't let them get acidotic. Don't let catecholamines be flying around and constricting the pulmonary artery. All things that make the TR jet worse. Some clinical pearls. Oxygen and CO2 and its effect on tricuspid regurgitation. If the patient's oxygen levels go down, they're going to constrict, hypoxic pulmonary vasoconstriction. Hypercarbia constricts the pulmonary vasculature. Pressure is going to go up in the right ventricle and worsen tricuspid regurgitation. Nitrous oxide, probably not a great idea in someone with severe TR and pulmonary hypertension, because nitric oxide increases pulmonary vascular resistance. Positive pressure ventilation and PEEP. If you have high peak pressures, inspiratory and PEEP, intrathoracic pressure can increase pulmonary artery pressure, worsening the TR jet, but it also decreases venous return. So be careful about peak inspiratory pressures and PEEP in a patient with TR. If a patient who has TR has a sudden decrease in SpO2 saturation unresponsive to increasing your FiO2, don't forget that there could be flow across the PFO. There could be so much blood and pressure in the right atrium that exceeds left atrial pressure, and flow could occur across that PFO from right to left. That's a right to left shunt, decreasing the SpO2. Up at the top shows a annular ring that can be put in a patient with TR to pull those leaflets together, pull the annulus together to make it non-regurgitant. So that's a tricuspid regurgitant repair. Hypertrophic cardiomyopathy, the last major topic. In this case, on the left, you're seeing a hypertrophied septum, and that hypertrophied septum can set up a scenario where the mitral valve leaflet is actually pulled into the LV outflow tract, creating mitral regurgitation. Also, the thick septum, along with the anterior leaflet being pulled out there, can obstruct flow going out to the body. So LV outflow tract obstruction, mitral regurgitation, characteristics of hypertrophic cardiomyopathy. Here's an echo picture, thick interventricular septum, the anterior leaflet of the mitral valve being pulled out into the left ventricular outflow tract during systole. If you look at the muscle fibers of a normal patient, this nice laid out fibers, as opposed to the hypertrophic cardiomyopathy, they have disordered muscle fibers, and the septum is thickened. The proximal acceleration of blood trying to get through this obstructed little orifice creates a venturi effect, which sucks the anterior leaflet out into it. That's called systolic anterior motion of the mitral valve leaflet, or SAM, and can cause severe decrease in blood flow going out into the aorta, and hypotension and low cardiac output state, all from that LV outflow tract obstruction. Our management goals of HOCM, and this was one of the most common key words related to valvular heart disease. Technically, this isn't valvular heart disease, but it's covered under this category. If you have someone with HOCM, you want to keep their afterload up. You want to do everything you can to keep their ventricle big, not emptied. Okay. So SVR up, phenylephrine. You want to keep their preload up, so give them volume. You don't want their contractility up because that makes the ventricle smaller during systole, so ephedrine and epinephrine and dopamine, usually bad choices. We want their heart rate relatively low so it has time to fill and pull apart that little mitral valve anterior leaflet away from the LV outflow tract. So the main thing that you want to do is this. If you have a patient who has severe hypotension, and we're going to jump to the third one here first, who has IHSS, remember that outflow tract is the pathophysiology, outflow tract obstruction. If they lose volume, they bleed suddenly, get behind on volume, that outflow tract obstruction is going to get worse. Phenylephrine can increase preload, can increase afterload, can be given as you're giving volume, but do your best to avoid any drugs that increase contractility, because dopamine, epinephrine will make things worse. In fact, classically, as you're adding more and more drugs like that, the patient gets worse and worse, and then someone comes in and recognizing that this is IHSS physiology, they stop all the beta stimulants and give a little phenylephrine and a little volume, and suddenly things get better. And even beta blockers after you have given volume replacement. So phenylephrine, volume, beta blockers, the management for HOCM. Obviously, the very first one, putting in a spinal or an epidural, could be bad for someone with IHSS. Sudden drops in preload, sudden drop in afterload worsens the LV outflow tract obstruction. We want to avoid major sympathetic stimulation, which would make the heart smaller from the beta-1 effects, and maintain our SVR and preload. That's our general anesthetic goals. One of the interesting things is there's a dissociation between the pulmonary artery catheter findings and TE findings in patients with HOCM. And basically just think this, that if you have a PA catheter in, what it's going to tell you is that if you have LV outflow tract obstruction, the pressure's high in the left ventricle during systole, you're going to see that pressure, and you're going to measure pretty high pulmonary artery pressures. You're going to say, oh, they're hypovolemic, or they have a failing heart, and you're probably going to do the wrong thing. You're going to add inotropes, or would be a really bad choice, as opposed to seeing it with TE and seeing the LV outflow tract obstruction, the acceleration of blood out the LV outflow tract, the mitral valve being sucked into the LV outflow tract. In that situation, you would say, aha, this is IHSS physiology. You're going to give phenylephrine and volume and maybe beta blockers. Antibiotic prophylaxis. New guidelines, cardiac conditions that are associated with high risk of endocarditis, infective endocarditis. If someone has a prosthetic cardiac valve in place or has used prosthetic material for valve repair, need to give them antibiotic prophylaxis. Conditions no longer requiring antibiotic prophylaxis, mitral valve prolapse, just because they've had rheumatic heart disease or have a bicuspid aortic valve, or an old patient with calcific aortic stenosis, you don't have to give them antibiotic prophylaxis. This ends a relatively long, thank you for sticking with me on this podcast, discussion of valvular heart disease. Here's a quote from Proverbs 17:22, "A merry heart doeth good like a medicine." I hope you have a great day today. Never stop learning, and thank you very much.